I'm Dr. Stefano Fazzini, Associate Professor in Tor Vergata, University of Rome. Together with the common iliac artery, the external iliac artery represents the main inflow for our leg. And if we consider that most of our patients are chronic patients with multi-level disease, treating at our best the iliac segment is paramount. This segment is very tortuous, has an S shape with a high flexible point in the distal segment at the level of the inguinal ligaments. And usually for this reason we use as scaffolding, we use a self-expanding stent. But there are some cons if we are treating calcified iliac artery in terms of underexpanded stent, in terms of fracture, and of course if we treat calcified lesion, we risk life-threatening conditions such as rupture. We should land our stents in a healthy zone, and sometimes this is not the reality, and sometimes we risk also the embolism. So many complications could occur if we treat calcified iliac lesions. Here is a case that illustrates to tackle calcified iliac arteries. This case was 71 years old male with lifestyle limiting claudication on the left leg with a walking distance less than 50 meters. He presented with the proximal external tight lesion and as many patients with multi-level, also another lesion at the level of the common femoral, another lesion at the level of the distal CFA. And we think that treating only the proximal one was enough for a claudicant. In particular, in this case, there was a big mismatch in terms of diameter between the common, between 14 and 20 millimeters, and the external between 8 and 8.5. So in case of stent, because of the internal was occluded, because of the turbulence in case of stenting, we should have been used the covered stents, probably two covered stents, or probably an iliac limb with a larger introducer. Of course, in this case, the option to do a good vessel prep and eventually leave nothing behind by using Shockwave L6 could be extremely interesting. Before using Shockwave L, as per protocol, we are used to do gradient pressure, measure in this case 41 millimeter of mercury before the treatment, and EVUS, extravascular ultrasound. So we check the duplex at the level of the CFA, in this case common femoral artery, so distal to the lesion at the level of the external, and we had a monophasic flow, monophasic waveform in this case. Then we started with the predilatation, 3.5 millimeter POBA, and then 5 cycles of L6 with the 10% oversizing, that is very important, referred to media. And then other 5 cycles. The first 5 at 2 atmospheres, the second 5 at 3 atmospheres, so very low pressure. That means very low barotrauma, very low risk of rupture. And after 10 cycles, we did the angiogram to assess the final results. Of course, as always, we do at least 2 angiograms with the multiple projection, and we are adding the EVUS control and the gradient pressure. We had no gradient pressure at the end, and the EVUS control showed us a triphasic flow. That means not only a better luminal gain, but also a better compliance. So, and of course, this is thanks to the Shockwave IVL treatment. Yeah, for sure, I will include the Shockwave L6 in my toolbox for iliac calcific disease, of course, to mitigate the risk during the procedure. Of course, the most important is life-threatening is the rupture of our vessel. So to increase the luminal gain and compliance for peripheral disease, and also will be very important for style access to increase the safety on the procedure and also to increase the feasibility for our aortic procedures.